Hi, my name is Dr. Somogyi, and I'm a plastic surgeon who focuses primarily on breast reconstruction after cancer. This is one of the most exciting fields in plastic surgery because breast cancer treatment really has changed to the point of being a treatable disease, and with survival rates of over 90%, we really do focus these days on quality of life and really improving patient outcomes and allowing patients to go back to normal life as quickly and as normally as possible. And so I'd like to give you an overview today of some of the things that we discuss when we talk about breast reconstruction. I'll go through a series of questions that are commonly asked. So the first is, when do I do my breast reconstruction? And so there are really two time periods. The first is called a delayed reconstruction, which means that the cancer is treated, whether it's with chemotherapy, radiation, or surgery, or a combination of those, and then surgery comes at some point later, whether that's 2 months later, or 2 years, or 5 years or more. It comes at a separate stage. That would be delayed reconstruction. The second time period, which is really the most common these days, is to do immediate reconstruction, which means that patients can be treated with chemotherapy sometimes before, but at the time of the surgery to remove the breast cancer, that's when the reconstruction is done as well. And if it's not completed at that time, it's at least started, and we'll talk about what that really means. And so that's immediate breast reconstruction, and that's really what we aim for. There are significant benefits to immediate reconstruction. Of course, there is fewer total surgeries, there is a shorter recovery overall, and in general, the aesthetic or cosmetic outcomes are better because we're preserving as much of the native breast skin and oftentimes the nipple, which we can fill or reconstruct at the same time. And often that's not the case with a delayed reconstruction, where a lot of the skin is removed so that the chest is flat for a period of time. The next question, which really is something we talk about a little bit later, is can my nipple be saved? And so again, today, with the field advancing at the pace that it is, we are very commonly performing what is called a nipple-sparing mastectomy. This means that not only is the breast skin preserved, but the nipple itself is also preserved, and the only tissue that's removed is the actual breast tissue beneath the skin and the nipple. This allows for a very nice and natural result, as you could imagine. There are a number of criteria that have to be met in order for us to perform a nipple-sparing mastectomy. The first is a technical consideration. If the breast is very, very large, then it's a very difficult operation to do, to remove all of the breast tissue and leave the skin and the nipple intact and healthy. If the second consideration is really more cosmetic. So if the nipple is in a very droopy position, or in a low position, or out of place, or there's significant asymmetry, a difference in position between the two sides, then keeping the nipple is not an excellent idea, because the reconstruction generally places the breast in what we'll call the normal position, or aesthetically appropriate position, and the nipple can't be moved at the same time, which means that it would be low, and there would be an imbalance between the position of the breast and the position of the nipple. So again, to review, a nipple-sparing mastectomy can be performed when the breast is of moderate size. Let's just say it's a C cup, B or C cup breast, and the nipple is in a good position to start with. The next question is, what type of reconstruction should I have? And really, we break that down into two categories. The first are implant-based reconstruction, and those generally involve silicone gel implants. Once the mastectomy is performed, usually at the same time of the surgery, the implant is placed within that remaining pocket, and oftentimes there are other materials used to support the implant. Those are called acellular dermal matrix in many cases, and that material and the implant provide the shape to the breast. That is probably the most common type of breast reconstruction. It is a shorter operation, usually about 2 to 3 hours per breast, and the recovery is a little bit easier than the other option I'm going to tell you about, and usually about 4 to 6 weeks until you're back to most of your normal activities. The second category of breast reconstruction is called autologous, or using your own tissue. And usually that's taking skin and fat from your abdominal area, sometimes from the buttock or inner thigh, but generally from the abdominal area, and reconstructing the breast using your own tissue. The most common of these is called the DIEP flap. DIEP stands for Deep Inferior Epigastric Perforator Flap. You don't need to remember that. And that just refers to the blood vessel that keeps that flap of tissue alive. And really what we do is remove all the skin and fat from the lower abdomen, similar to a tummy tuck, and bring it up to the chest area where the blood vessels are connected to other blood vessels in the chest so that it is alive. It's your own tissue. And then we cover that with your own skin, which was left behind from the mastectomy. And that provides a very natural breast reconstruction with long-term results that are excellent. Of course, that's a more complicated operation. Surgical time can be 5 or 6 hours per side, and it involves a hospital stay of 3 or 4 days to ensure that that flap is healthy and happy in its new location. And the recovery is a little bit longer as well, more like 8 weeks until you're back to normal activities. And so those would be the two general categories for breast reconstruction: implant-based and autologous or flap-based. The last question that we are commonly asked is, can my nipple be reconstructed if I'm having a mastectomy and the nipple cannot be saved? And so this is something we talk about after all the reconstruction is done and everything has healed and settled in position. But the short answer is yes, there are several options for nipple reconstruction. The most common these days is a 3D nipple and areolar tattoo, which are really excellent. They hide the scars and they provide a really nice cosmetic and aesthetically appropriate reconstruction. The second is if it's unilateral, one side, and the patient wants a projecting nipple, right? So an areolar tattoo is flat, but if you want a projecting nipple, then we can actually make a nipple out of a graft from the other nipple, or just by folding the skin in a certain way to make a nipple. This is a little bit more complicated, and these nipples tend to flatten out over time, and so that's why the nipple areolar tattoos have really become the most common. So I hope that provides an overview of breast reconstruction, timing, whether or not you can save the nipple for nipple-sparing reconstruction, what type of reconstruction, implants or flap-based, and what we can do with the nipple after the fact if it can't be saved.